of a society. The same disclosures apply for this particular lecture. Aneurism sac behavior after EVAR is variable. Sac stable behavior is perceived as an adequate outcome. Sac regression has been found to correlate with long-term success. An increase in sac diameter will trigger reinterventions in most patients to prevent late rupture. Prior publications, for example, the Cleveland Clinic experience in 2003, concluded that significant differences in the frequency of complications were specific for the endovascular stent graft design. This should be incorporated in developing of the next generation devices. This publication was back in 2003 and recruited from 1999 to 2002 and really reflects first generation North American commercially available devices. Another more up-to-date publication from France supports the notion that sac retraction is a robust indicator for clinical success. In the patients that experience sac reduction group on your right, with a mean follow-up of 50 months, they experience less death, less surgical conversion, less incidence of type 1 or type 2 endoleaks, and less secondary intervention rates compared to patients who did not experience sac regression. So our study purpose was to evaluate the short and long-term outcome of patients who underwent EVAR with bifurcated prosthesis in our institution for large, more than 5 centimeter infrarenal AAAs, and to specifically determine the influence of stent graft design in aneurysm sac behavior. It's a retrospective review of a prospectively maintained data set. It's a consecutive series from 2002 to 2011. 342 patients underwent EVAR. 285 of these were eligible for this study. Excluded of these 57 patients, most of them really were excluded because their aneurysm infrarenal aortic sac was less than 5 centimeters. Patients and methods, the aneurysm size was defined as the minor axis of the largest axial cut of the aneurysm on two-dimensional CT scan. EVAR device was selected based on the surgeon's preference. We have a post-EVAR institutional protocol that determines a CT scan as 1 month. This is the baseline CT scan, which compares sac regression data or sac behavior data, 6 months, 12 months CT scans, and yearly thereafter. If there's any new finding, we will reset the surveillance protocol. Angiogram was obtained when the presence of those parameters described in the slide. The sac definition, stable sac is any sac within 5 millimeters of the maximal diameter compared to baseline. Sac decrease was observed and noted when less than 5 millimeters compared to the baseline, and increased sac was recorded when more than 5 millimeters of maximal diameter compared to the baseline. Reinterventions were triggered when migration with minimal ceiling zone apposition, with or without the presence of endoleak. Any type 1 or type 3 endoleaks led to indicate reintervention. Any type 2 endoleak with an increased sac diameter, symptomatic thrombosis, and we did not perform reinterventions for persistent type 2 endoleaks. I'm looking forward for the next presentation of type 2 endoleaks here in this meeting. The main outcome measure was long-term post-EVAR aneurysm sac diameter by implanted stent graft design. And those are statistical methods that we use. There were 281 males, average age 72, most of them Caucasians, with a typical display of cardiovascular risk factors. The baseline aneurysm sac at 1 month was 5.6 centimeters after EVAR. The perioperative mortality is recorded in 2 patients. Graft implanted by design, modular devices, 68% of the cohort, and 32% of the cohort received a unibody design. The overall mean follow-up was 44 months, ranging from 1 to 123. The mortality long-term is 28%. The late aneurysm-related death is recorded in 0.7% for an overall aneurysm-related death of 1.4%. The overall endoleak incidence is 22.9%. Most of them type 2 endoleaks. Type 1 endoleaks were 50-50 type 1As and type 1Bs. Very little type 3 endoleaks, and endotension was recorded in 12 patients. The overall sac behavior of the cohort, 41% of them actually regression was noted, 47% remained stable, and 12% of the patients who received EVAR increased their sac diameter post-EVAR. The fate of this particular group, we noticed 68% evidence of endoleaks. 20 reinterventions in this group was performed, electively in 18 patients, 2 in the emergent setting. Non-reintervention in this group, 14 patients currently under surveillance. The distribution of the type of endoleaks, there were more type 2 endoleaks, but more type 1 endoleaks, close type 2 endoleaks. The mortality overall for the patients who received EVAR and increased their sac was 3%, significantly different from the patients who did not increase their sac. The elective mortality was 0, but the emergent mortality was 50%. That was the primary driver of the mortality increase. When you analyze the cohort by stent graft design, you'll notice that there was no significant difference in the incidence of endoleaks types or migration, thrombosis, conversion, or late rupture, whether they receive a modular device or a unibody device. The same applied for the site behavior by stent graft design. There was no significant difference in the behavior of the sac post-EVAR, whether the patients receive a modular device or a unibody system. In conclusions, ladies and gentlemen, Mr. Chairman, our data suggests, regardless of the stent graft design, 12% of patients will experience increase in aneurysm sac during long-term follow-up. Sac diameter did increase reinterventions and aneurysm-related mortality. In our experience, stent graft design was neither predictive of this occurrence nor of any other EVAR-related complications. Thank you for your attention very much.
Obrigado, Dr.